Good afternoon, everybody. It's Casey, the current president for MACVPR. Thanks again for joining us for another webinar that we got going on for the year. Um, Thanks to the board for being able to put all these together throughout the year. And thanks to Trina for being able to hop on and take care of this for us today as well. Appreciate you doing this. Um, we do have approval for continuing ed. One contact hour is available. You do have to watch the webinar and its completion, and then you also have to complete the evaluation form that was sent in the invite. I'll make sure I post that evaluation form to the chat field as well, so you guys can access it there. So this is recording. You do have the ability to go back and view this. Continuing ed is available for 1 year from today's date. So even if you're seeing this 4 months from now and you complete this in its entirety, you can still fill out the survey and we can still get you continuing ed for this. If you do need more help links and things like that, feel free to find my information directly. It's on the MACVPR website under the officers tab. You can reach out to any of us and we can help you. And I'll make sure I post that here to the chat field as well. If you guys do have Q&As, please use that chat field down below. I'll circle back around at the end of this talk so we can get those questions answered for you guys during this. And that way we can get that taken care of. Today, our talk's on wildfire and health impact. Dr. Zach Wetstein, he's a fourth-year residence physician at the Department of Emergency Medicine at the University of Washington School of Medicine. He attended the University of California, San Francisco School of Medicine, and prior to that, graduated from Stanford with a degree in human biology. His academic and research interests include health impacts of energy development to work and communication of the effects of change climate on health. He completed an NIH-founded research fellowship collaborating with the California Department of Public Health and U.S. Environmental Protection Agency in a study of cardiovascular health outcome associated with wildfire smoke exposure in California. So with that said, Dr. Wetstein, I'll turn it over to you for the presentation.
Thanks so much, Casey. Good afternoon, everybody. It's really a pleasure and an honor to be here with you to talk a little bit about the public health implications of wildfire smoke exposure. And seems like it's a very opportune moment as there's fires blazing across the country and smoke blowing everywhere. I'll take an opportunity to talk about just some of the latest research in wildfire smoke health impacts and highlight one study that Casey mentioned that we did with the California Department of Public Health and the US EPA. But before I start, I just want to let you know I don't have any conflicts of interest to disclose. The research that I'll talk about later was generously supported by the NIH through the University of California, San Francisco. The presentation today does not represent the official views of the NIH, the California Department of Public Health, or the US EPA. So I just want to talk about the basic outline and objectives today. There's a lot of technical information along the way, and so we won't be able to stop, but please do write down your questions or put them in the chat and I'd be happy to address them towards the end. But a couple of our goals. So hopefully at the end of this session, you'll be able to describe the burden of wildfires in the Western US and the projected impact that climate change will have on wildfire seasons. To summarize the wildfire smoke related health outcomes and identify vulnerable populations. To explain the pathophysiology of air pollutant related changes to the circulatory and also to the respiratory system. To relate the potential for using social media and smartphones to predict smoke plumes and health effects for individuals. To describe methods for mitigating exposure and risk for the community. And of course, to discuss opportunities for health system preparedness for wildfire season and the relevance to the practice of cardiac and pulmonary rehab. So as you may know, wildfire smoke is certainly a regular occurrence in the Western US, but unlike the typical images you may see in the news of these dramatic pictures of fire and smoke, more often it looks like this. It's a blanket of haze. This is a photo that I took in 2017 in Yosemite Valley. And of course, apart from the aesthetic impacts of the smoke itself, we know that wildfire smoke is harmful to human health. And unfortunately, I would imagine this is a scene that's probably familiar to you in Montana, perhaps even right now. So wildfires are a natural part of these forested ecosystems. We see them primarily in the US in the Southeast, as well as in the West. However, our change in climate is increasing the duration, the intensity, and the frequency of large fires. Concentrations of air pollutants due to wildfire smoke are projected to increase up to 400% in the next 30 years. And you can see this trend here in this slide. Within the slide is over the last 40 years or so, you can see how as temperatures increase over that period of time, the number of large fires has also significantly increased. And as we humans move further into what's called the wildland-urban interface, the risk of exposure increases even more, and that's especially true in Western states. So this is one of the pictures of the wildland-urban interface over the last 20 years or so in the Western US. And it's a huge factor driving up the risk of wildfire smoke exposure is humans moving into a region where these fires are occurring at the edge of the forest, essentially. So the WUI, as some people call it, is the interface of wild spaces in our communities and neighborhoods. So as we continue to move into forests, our homes and communities are then in regions that are already prone to wildfires, and that affects our relationship with fire management. So whereas in the past, maybe fires would have burned naturally in those ecosystems, when people live within those forests, then we have to repress a lot of fires to protect property and homes. And as a result, a lot more fuel builds up and can lead to significantly hotter and more intense fires. So I mentioned this map shows a lot of the regions where the WUI is located, and you can see that a lot of it's located in California, in Idaho, and Montana is really no different. This is one image of documenting some of the region that would be included in the WUI in Montana. This is from 2011, so it's a bit outdated, but you can see that it's located primarily in the western part of the state. And although geographically it looks quite small, about 62% of Montana citizens live in the WUI and are at greater risk of immediate exposure to wildfire smoke and wildland fires. And one documentation that I found was that at least 1 in 8 new homes built in Montana is built at this interface. So that's maybe where the particular fire is located, but it's important to note that it's really not just the fires that affect humans. It's the smoke goes well beyond the location bordered by the particular fire and goes across county lines and state lines and even country borders. So these are satellite images from 2015, and they demonstrate the complexity of the wildfire smoke and the plumes that they generate. So the red dots on here are the individual fires, but you can see that the blue-white smoke traverses the state boundaries, fills the whole Central Valley of California over just a few days, but goes well into Nevada and Oregon. And even more recently, some pictures from 2018, the fires in California, Oregon, Washington, and British Columbia sent smoke and soot, which is what the image on the right shows, well across the country and into Canada. So you can see these massive plumes of smoke and particulate matter. The last 2 summers were also no exception. This is from 2019. The devastating Kincaid fire in October of 2019 was the largest California wildfire at that time and the largest ever in Sonoma County. And there was also a new threat that fire posed, which was the rolling blackouts. So in the context of those fires, the power utility cut power to over 3 million people to try to mitigate those fires. So sort of added a new hazard to the smoke exposure itself. So you can see the satellite image on the right where that Kincaid fire was located, and that smoke was blowing well out into the ocean and blew up into the northern states and then back into the Midwest as well. And then last summer here in Washington, the 2020 fires were very intense in Washington and Oregon. We had more individual fires in Washington than any other year on record in 2020. And we had over 800,000 acres burned on the west side of the Cascades, which is a region that typically does not see a whole lot in the way of wildfires. And that was right at the end of September. Most of our fires are actually in the eastern side of the state, which is a more drier, high plateau region that's a little bit more prone to having wildfires. So these were very unusual in their location and their intensity. And the smoke from these fires was blown offshore, and the effects actually persisted for weeks. You can see how on the photo on the right, just a week after the one on the left, how the smoke just hung over the state of California, Oregon, and Washington. And just some preliminary data from last year showed that there were significant increases in the population in Washington who were exposed to very unhealthy or unhealthy air. So we had higher numbers, over 6 million people that were exposed to very unhealthy air for a period of 1 to 2 weeks on end, which was really unprecedented. And of course, Montana is also no exception to that. You may remember 2017 was a particularly intense wildfire year in Montana. 1.3 million acres burned, and over 4,000 wildland firefighters were involved in the fight at that time. There were two large, what would be called mega fires that season, the Rice Ridge and the Lodgepole Complex fires. They burned nearly a third of the acres that season. And Montana spent a record number of funds on firefighting and recovery efforts. And they had a $200 million budget shortfall as a result of that. And one thing that's important to note is of all the Western states, Montana's had the greatest percentage increase in large fires in the past 50 years. And that's what you can see here on this graph. Then the trend is really only expected to continue. You can see that Montana suffers from fires in the state in this photo down here on the bottom, the satellite photo. But as we've talked about so far, a lot of the regions upwind from Montana are also very prone to wildfires and so blow a lot of the smoke in. So not only are the fires occurring in Montana, but you're also suffering from a lot of the smoke that's blowing in from British Columbia, Washington, Oregon, et cetera. And of course, this is just from the last few weeks here. Fires in California, in the Southwest, in Canada, as well as Oregon have sent wildfire smoke well across the nation. So the bootleg fire in Oregon is seen in the bottom right, and that's been driving a lot of smoke towards Idaho and Montana. And as of this week, it was around 400,000 acres and only 30% contained. This capture from a tweet from the East Coast shows how some of the wildfires on the West Coast have blown smoke and affected air quality on the East Coast. So some people have just been documenting these incredible sunsets, but what that represents is really all this particulate matter and all these other compounds that have blown well across the country. And that's what you can see in the image on the upper left is modeled data of the particulate matter that's been blowing across the country. And I captured this last night from one of the, from just some satellite data just from the day yesterday. So this is a series of satellite data just looped together. And you can see how some of the fires in Northern California and Oregon have been blowing all this smoke that's been heading, unfortunately, right towards you guys. But of course, wildfire smoke is not just limited to North America. It's really a global phenomenon, from naturally occurring wildland fires to those set in the process of slash and burn agriculture. This map is from a study that showed estimated averages of global mortality from wildfire smoke exposure around the world. And they estimated that there were over 300,000 annual deaths worldwide that could be attributed to wildfire smoke exposure. And that's each year. And most of those are concentrated in Africa and in Southeast Asia, where most of these tropical forest fires occur for agricultural purposes. And one particularly devastating year was in Indonesia in September of 2019. There were over 2,000 wildfires that burned across Indonesia, most of which were set for agricultural purposes, and they resulted in respiratory problems for nearly 1 million people and an untold number of cardiovascular problems. I mentioned many of these fires were originally set for clearing the brush for palm oil plantations, as well as for wood pulp for paper making. But the fires burned out of control and they tore through pretty sensitive rainforests. Many of those are peat forests, which will smolder for a very extended period of time and are very difficult to control, similar to what we have in the Southeast in the US. These fires are an annual phenomenon, and they use these slash and burn methods for opening land during the dry season so that they can plant them for agricultural reasons. And you can see from a satellite standpoint as well, you can see that the whole region was just covered in a plume of smoke and particulate matter. I'm going to use my mouse here. If you can see this. This is the only region on this map that's not affected by smoke. The rest of the haze is really representing particulate matter and smoke that's covered the whole region. And it goes well beyond Indonesia. It affects a number of the neighboring countries as well. And you may also remember in Australia, the fires in January of 2020 were truly unprecedented. Over 50 million acres burned in Australia. Thousands of homes were destroyed. 35 people or so were killed, and a striking estimate of over a billion, with a B, animals were killed in the context of these massive wildfires. So you can see in this picture on the bottom right, the smoke just covering the southeast portion of the country. And this is where the fires were primarily burning, but they spread well across the country and also occurred in the setting of very severe drought. And Montana actually sent 9 wildfire and aviation management personnel to Australia to actually help in the firefighting effort. So certainly not just an issue in the US. And climate change is playing a huge role here in leading to an increased frequency and intensity of hot and large wildfires that then contribute to the hot and dry conditions that are a setup for the massive fires themselves. So over the past 50 years, snowmelt has started earlier in the season, which contributes to early vegetation growth in addition to drought-like conditions. And then in the summer and in the warmer conditions that are generated in these higher elevation forests where they're not typically exposed. So the thermocline, if you will, is getting to higher latitudes. So there's fires starting at even higher elevation. So you end up having a fire season that starts earlier, that ends later, and then contributes to nearly year-round wildfire conditions in regions of the US, sort of like California, for example. So the plot on the left here shows the trends in early snow melt, increasing temperatures, and then increased frequency of these large fires over the past 50 years. And this plot on the right is a separate study, but it shows that they found that half of the acres burned over the past 30 years could be attributed to human-caused climate change alone. So the black line is what would have been expected without climate change. The yellow line, what could be attributed to climate change impacts on temperature and humidity. And then the red line is what we've observed as a combination of those two. And we know that the risk of smoke exposure from fires is only projected to increase in the context of climate change. This is a study from 2016, and they used a number of climate models to generate a fire prediction model, and they identified the counties at greatest risk of smoke waves in the present and then in the future under moderate climate change conditions. So what they generated was called the Fire Smoke Risk Index, and it summarizes the overall wildfire particulate matter exposure risk based on the duration and the intensity and the frequency of these smoke waves. So what we see here going from sort of the early 2000s to the 2040s is that in the future, there's a big shift in the number of counties to the highest risk category, which is outlined in red. So if sort of to put it another way, if you will, it went from roughly 50 million people to 90 million people exposed to a smoke wave in every wildfire season. And I think what's really striking is the counties at greatest future risk include those in Northern California, in Western Oregon, in Idaho, and then in Montana as well. And so I think a big question is, what is this going to look like in the future? Should we be expecting that we're going to just be performing our daily activities with this backdrop of increasing fire intensity and duration? We do see from the data that pretty convincingly that our fire season in the West is only going to keep increasing in length and with greater frequency and intensity of these large and hot fires. So it's important to know the health implications of what this wildfire smoke exposure poses to us and then what we can do about it. This photo is a little striking, but it's from a fire in Eastern Washington in 2017. called the Eagle Creek wildfire. It was across the Columbia River, which you can't actually see in this photo, but it was started, of course, by a human, as many of the wildfires in the West are. It was a 15-year-old who tried to throw a firework and it exploded in the brush, unfortunately. So let's dig into that a little bit deeper. What is it about wildfire smoke that causes health impacts? So wildfire smoke contains loads of compounds, particles, gases, and organic compounds, to be specific. Particulate matter is one of the most studied and is one of the predominant components of wildfire smoke. And others include carbon monoxide and ozone, volatile organic compounds, polyaromatic hydrocarbons, and then nitrogen oxides. All of these have their own associated health consequences. I'd say particulate matter probably makes up the biggest share of wildfire smoke, and at this point is the most well studied. They're very small particles that result from the combustion. They're smaller than the width of a human hair, as you can see in this diagram here. And they're made of a combination of things: carbon, metals, dust, and other combustion products. PM10 are particulate matter that are 10 microns in diameter, and those would be the blue dots in this photo. PM2.5 are 2.5 microns. Those are the red dots in this photo. And the PM10 essentially makes it into the airways, but gets trapped there. And PM2.5 can cross through the alveoli and enter the circulatory system. And so they're small enough to interact with the capillary beds and enter the bloodstream and cause a host of health consequences, which we'll talk about in a second. Today, I'm going to focus on particulate matter in more detail because of its well-studied relationship with respiratory and cardiovascular health outcomes. And as I mentioned before, it really makes up the bulk of the products within wildfire smoke itself. But before I dig into the specific health impacts of wildfires, I just want to address how challenging it really is to study. So because wildfires are rapidly evolving situations and we want to study them on a population level, we end up resulting in using what's called administrative data. So looking at humans accessing clinics and hospitals and emergency departments. Unfortunately, this data is really often not available in the moment, and it takes a long time to put together. So we tend to use these data sets and study them from a historical perspective, which leads to some challenges in drawing conclusions because it's not a prospective study. Wildfires tend to be brief. They tend to occur in rural areas, and as a result, there's smaller population sizes that are exposed, which affect the power of our calculations and our statistical analysis. And this diagram here shows if you take a look at the whole pyramid, it includes all of the people that could feasibly be affected by wildfire smoke. Most of them, the bottom of this pyramid, are having minor health symptoms that would be pretty hard to detect. Subclinical effects or no symptoms at all. We tend to focus when we're doing these analyses on the very tip of the pyramid, the deaths and the hospitalizations. And so that's what we'll talk about today, but it's important to notice that many more people are probably affected than we're able to pick up when we just look at the numbers of clinic visits and hospitalizations and ER visits. So let's talk about the health implications of wildfire smoke. First, just to talk about respiratory disease. It's really what the majority of the studies have focused on, these respiratory health outcomes. I think it makes intuitive sense that breathing in smoke products would lead to increased rates of respiratory disease. And so that's where a lot of the studies are focused on. And it's also easier to characterize those events in particular. So there's an abundant evidence at this point that wildfire smoke exposure leads to exacerbations of reactive airway disease. So asthma exacerbations like ED visits and hospitalizations, as well as COPD exacerbations. There's a growing association between smoke exposure and both upper and lower respiratory infections like bronchitis and pneumonia. And I think it makes sense. The image on the right here can exemplify sort of the pathophysiology of acute exposure affecting the alveoli, but then, as I mentioned before, high generation of reactive oxygenation species and inflammation and then cell death. We'll talk about the pathophysiology of the cardiovascular disease in a minute, which is a little less straightforward. But you can imagine this is similar to the pathophysiology of the development of COPD in someone who is smoking tobacco. Cardiovascular disease, on the other hand, is less consistently studied, and there have been more inconsistent findings in the literature. A lot of this comes from the ambient air particulate pollution literature. So thinking about air pollution coming from industry, from power generation, um, and those on large population level studies have been clearly linked to cardiovascular outcomes like cardiovascular disease, ACS, and stroke. In the wildfire literature, it's less conclusive. So we've seen some associations with out of hospital cardiac arrest, but it's been less consistent with conditions like MI and stroke. So some studies have demonstrated associations between smoke and these outcomes, and I will talk about those in a minute. But as I mentioned, it's sort of, we're using the ambient air particulate literature to generate the hypotheses essentially for how this might actually occur, and then trying to study these on the level of large population studies affected by wildfires. So the associations that have been investigated so far, hypertension, arrhythmias, ACS, and out-of-hospital cardiac arrests, exacerbations of congestive heart failure, and stroke. So some studies have found associations with these outcomes, others have not detected an association. And I'll point you back to that pyramid that we looked at before. These are relatively rare outcomes, certainly as compared to things like an asthma exacerbation or a COPD exacerbation. And so some of the interpretations so far have been that we just haven't studied large enough populations to detect whether the wildfire smoke itself leads to cardiovascular outcomes like these. So let's talk a little bit about the pathophysiology. How does wildfire smoke exposure lead to cardiovascular outcomes? So I mentioned the particulate matter. This is the fine particulate matter, the PM2.5, that enters the airways and then interacts with the capillaries and enters the circulatory system. So there's three major ways that can result, sort of three pathways that starts. There's the autonomic system activation, the systemic inflammation, and then the direct effects of the particulate matter in the bloodstream. And so downstream, these lead to a couple of factors. So the autonomic system activation is sort of like a bolus of epinephrine. Increasing your heart rate can increase cardiac dysfunction and arrhythmias. The inflammation and the effects of the particulate matter in the bloodstream can affect your coagulation profile and activate platelets and cause endothelial dysfunction, all of which increase your risk for blood clot formation. So what this means at the end of the day is the clinical outcomes you could think of that these may lead to would be, in the case of autonomic system activation, heart failure and cardiac arrest, and from VFib or VTAC and stroke. Whereas the blood clot formation component may lead to things like ischemic heart disease or PE or stroke as well. So I'm going to talk about a few of these conditions in particular and some of the evidence that we have to date. So first, just talking about arrhythmias, and I'm going to focus on ventricular arrhythmias here. The study on the left was a study of 200 patients with implantable defibrillators in Massachusetts, and they studied the relationship between ambient air pollution, particulate matter, PM2.5 in particular, and ventricular arrhythmias, as well as ICD discharges. So they found a dose-dependent relationship between PM2.5 exposure and rates of VTAC and VFib. And you can see as the graph moves further to the right with increasing doses of PM2.5 that the odds ratio for defibrillation went up. And this is a separate study on the right. This was an Italian multi-center study of 280 patients also with implantable defibrillators. And they looked also at episodes of VTAC and VFib associated with particulate exposure. And they stratified by PM10, which were the bigger particles that get trapped in the lungs, and PM2.5 that enters the bloodstream. And they also found a dose-dependent response. So as the concentration of the particulate matter went up, you can see how the rates of the ventricular arrhythmias and the ICD discharges went up as well. I do want to note that these are studies of ambient air pollution. These are not wildfire in particular. So again, this is sort of particulate matter that's the result of industry or power generation or transportation. However, they did still find a relationship between the particulate matter itself and these clinical outcomes. And similar relationships have been found for other arrhythmias, PVCs and AFib, SVT. However, I would argue, and I think you'd agree with me, that these are more clinically relevant when they're going into VTAC and VFib, that those are more clinically significant. Similarly, for ischemic heart disease, there's strong evidence for a relationship between ambient particulate matter, PM2.5, and ACS, ranging from angina to STEMI. So I'll show you a couple figures just to highlight this from a few papers. So this one here is a study of over 11,000 patients with acute MI in Belgium, and you can see the seasonal variation. On the bottom is the PM2.5. And on the top is the rates of acute MI each day. And so you can see how the pattern of MI really correlates quite nicely with the PM2.5 concentration and how they parallel each other. This was over around a 4-year period. This study is more compelling because this is not just a retrospective analysis looking at sort of the one before was sort of an ecological study, but this one is a study of 20 years of data of 16,000 cases of ACS in Utah. So from the 90s to the 2010s. And all these cardiovascular outcomes were identified on heart cath. So really good outcomes data. So they use this data to study the relationship between short-term exposure to particulate matter, PM2.5, and a risk of STEMI. And the triangles on this plot represent a threshold. So people who were exposed to greater than a concentration of 25 of PM2.5, which is actually pretty low. So focus on the triangles. The circles were sort of the control group. And you can see that the odds are significantly elevated for those with risk factors for CAD. So people who have a history of hypertension, hyperlipidemia, CHF, older men. So what you see here is there were statistically significant increased rates of STEMI for those with cardiovascular risk factors when they were exposed to particulate matter over this 20-year period. And so you can see that those who have, so they sort of hypothesized that those with the PM2.5 exposure were related to destabilization and plaque rupture. So you wouldn't think necessarily that the PM2.5 exposure would cause the plaque to form in such a short period of time. However, the resulting pathophysiologic changes from the particulate matter exposure could be that triggering factor to cause that plaque to rupture and lead to STEMI in this case. And I'll focus on one more study here. This is from Australia in 2007, data from 2007. So they were looking at PM2.5, this time from wildfires and out of hospital cardiac arrest, which is plotted on the left, and then ischemic heart disease admissions to the hospital on the right. So this was also using an administrative data set and a case crossover design. They had over 400 out of hospital cardiac arrests in this study and 3,200 admissions to the hospital for ischemic heart disease. And so you can see in the plot on the left, there's a significant increase in out-of-hospital cardiac arrest, primarily among older folks and among men. And then you see similarly on the right, older folks and women actually, there was an increased risk of admission to the hospital associated with the particulate matter. You might argue that actually the disease was more significant among men, so they actually died in the field and didn't make it to the hospital to be admitted. So I'm not quite sure how to interpret the gender differences there, but what they did find in this study was an increased risk of cardiac outcomes in the setting of wildfire-related particulate matter. And I want to highlight that these other studies I've talked about so far, many of them are related to the ambient air pollution literature. This one is actually from the wildfire literature. So just taking a step aside from the health implications directly, I think it's important to also consider the impacts on the environment from these massive fires. So I mentioned that wildfires are natural in these ecosystems, but what is not natural are these very massive fires that essentially burn the forests, the young trees and the old trees, and result in things like sterilization of the soil. So these fires are typically used to these low level low intensity fires that burn with some regularity. But as I mentioned before, a lot of our fire suppression activity in the US has resulted in a huge increase in the amount of fuel for these fires, so that when they do ignite, they burn very hot and very intensely. So we're just starting to understand the ecological implications of these massive, massive wildfires that occur on pretty regular basis. This is a photo from Mount Rainier in the year after a fire burned there in 2017. I think important to note also, I'm not going to focus on this too much today, but the implications for water quality is quite important as well. So wildfire themselves, they result in a loss of shade cover and then decreased soil stability, which leads to erosion and then debris. And this nutrient-dense runoff then enters our waterways, and with a lot more solar radiation from the lack of shade cover can lead to pretty harmful algae blooms. The dissolved solids themselves in the runoff can result to challenges in water treatment and water quality. Many of these forests are sort of upstream of our reservoirs and our drinking water sources. And so places in Colorado where this photo on the left is taken, this is from the Poudre River, which is a water supply for a lot of places on the Front Range. And they've had immense problems with water treatment in the setting of these massive fires. And something we still are only starting to understand is the implications of the fire retardant. That's what you see here on the right, is the fire retardant entering the waterway. A lot of these are pretty long-standing and persistent chemicals that we just don't know the implications of that in the waterway, implications on water treatment and then drinking water as well. And then finally, it's important to consider some of the economic costs of these increasing frequency and intensity of wildfires, not just on the damage caused, but also on the lost productivity and the wages, as well as the costs of firefighting. And so this is one study that they were looking at the economic impacts around the United States. And they estimated that the annual societal costs of wildfires were around $11 to $20 billion each year. And they were primarily the disproportionate share of those economic costs was located in the Southeast and then in the West. And that is also independent of the public health implications, thinking about the rates of emergency department visits and hospitalizations and premature death and illness. So there are pretty drastic economic implications that we're also only just starting to quantify. So next I'll focus on the findings of our original study, looking at the cardiovascular impacts of wildfire smoke in California. So I spent a year working with a team from UCSF when I was a medical student a few years ago, and the California Department of Public Health and the US EPA to study the cardiovascular health impacts of wildfire smoke exposure in California. So our question in this study was, in California in 2015, which was a pretty intense wildfire year at that time, was the wildfire smoke exposure associated with visits to emergency departments for cardiovascular disease and stroke? So we did a time series analysis, and we looked at ED visits from May through September of 2015. In California has what are called 15 air basins, so regions that are sort of isolated by the movement of their air. And so we looked at 8 of the 15 of those air basins, really the ones that were most affected by wildfire smoke. So we used data from satellites from NOAA. They have a program called the Hazard Mapping System, which we use to estimate the daily numbers of PM 2.5. And we categorized their smoke exposure as either light, medium, or dense. And then we used health outcomes data from the OSHPA database, which we basically had counts of emergency department visits from each zip code for different discharge diagnoses. We also considered some covariates like the population size within each zip code, and then the heat index, so controlling for things like relative humidity and temperature. We did what's called a quasi-Poisson regression analysis in our time series analysis. So we looked at lagged exposures of up to 4 days. And what this means is a lag of 0 essentially means the health outcome occurred on the day of the smoke exposure. whereas a lag of 4 was essentially exposure 4 days ago, and then the health effect happens today. So we looked at a range all in between. And this expression at the bottom here sort of represents the factors that we included in our model. So we had terms in there to consider the density of the smoke, the day of the week, the heat index, as I mentioned before, the seasonality and the time of the year, and then the population size. And then we stratified all of these results by the age and the sex. We also included control categories of acute appendicitis and long bone fractures because we couldn't, based on the pathophysiology, which we discussed earlier, we didn't have a rationale for how those might be related to wildfire smoke exposure. So we thought that those would serve as appropriate controls. So just to summarize all this, so we conducted a time series analysis over 5 months in 2015. We looked in 8 of the 15 California air basins, and we used smoke exposure data from satellites from NOAA and ED discharge diagnoses with lagged exposures of 0 to 4 days to study the association between wildfire smoke exposure and emergency department visits for stroke and cardiovascular disease. So this is a table of all of the diagnoses that we included, and you can see we had over 360,000 cardiovascular diagnoses, 15,000 stroke diagnoses, 230,000 respiratory diagnoses, and then all told, roughly 1.2 million ER visits included in this analysis. And you can see this is the region of California that we included in our study. So the areas outlined in black represent the 8 air basins that we included in our analysis. And you can see the colors are for each individual county. And you can see how the regions that we included in our analysis were the counties that were exposed to the highest levels of smoke. So the darkest regions had around 50 to 60 days of smoke out of 150 days in the study. So roughly a third of the days in this study, they were exposed to wildfire smoke on some level. So these are and you can see in there some of the major cities in California, which were included in this analysis. So let's talk a little bit about the results here. And I'm going to show you a number of plots. They all sort of, they follow the same structure here. Across the bottom, each individual box is a different diagnosis category. And then as you go from left to right within each box, it represents increasing density of smoke. So light, medium, and then dense smoke. And then the outcome plotted is the risk ratio or the risk of the event occurring based on the analysis with the model. So these represent our risk estimates and then the 95% confidence intervals for each. So this figure here shows the calculated risk ratios and the 95% confidence intervals. And this is just for the summary diagnoses. So all-cause cardiovascular, all-cause stroke, all-cause respiratory, and then appendicitis, which is our control. And this one here shows you just for adults over the age of 65. And so you can see that with increasing exposure to a higher density of smoke, if you will, that there were increased risk of cardiovascular disease, stroke, and respiratory conditions. And we did not see an association with appendicitis. You can see that it sort of crosses a risk ratio of 1.0, whereas the other ones don't. And we did not see these same outcomes when we considered other age groups. So in younger adults and then adults between the age of 45 and 64, there was not a consistent relationship seen as there was for adults over the age of 65. And if we break this down and look at the individual diagnoses themselves, I'm going to focus on adults over the age of 65 because that's the only group that we found these effects with. And I'm going to now show you the results over a period of those 5 days. So lag of 0 is the day of exposure up to lag 4, which is 4 days after that exposure. And similarly, we still have the risk ratios plotted on the y-axis here. So you can see the risk over time for these individual diagnoses for adults over the age of 65. So you can see the all-cause cardiovascular, the impacts were within the first 2 to 3 days or so. And we did find relationships between smoke exposure and ischemic heart disease, primarily among lags of 0 to 2 days. And as we go up in intensity of smoke, so yellow was exposure to light smoke, orange is now medium smoke, and red is dense smoke. So the confidence intervals get wider because we had less data, but you can see that they tend to increase the risk of the outcome with the increasing density of smoke. So increasing intensity of smoke leading up towards denser smoke exposure was more likely to result in these clinical outcomes within the first few days after exposure. Similarly, if we look at other outcomes like dysrhythmias, heart failure, and PE, as we increase the density of the smoke exposure, we tend to see these outcomes more significant with a higher risk ratio or a higher risk of those events happening. And then finally, for outcomes, stroke, respiratory outcomes, and bone fractures, as we increase the risk, or as we increase, the density of the smoke exposure, we see increasing risk of these events happening for stroke, for respiratory conditions, and then interestingly enough, also for bone fractures, for long bone fractures in day 0 and day 1. So in our study in particular, we concluded that wildfire smoke was associated with cardiovascular and stroke disease outcomes, particularly among adults over the age of 65, and most often at the first 2 to 3 days after exposure to the wildfire smoke. We also found associations with respiratory outcomes, which has been documented elsewhere in the literature and was not quite the focus of our study. We did not find an association with our control condition of acute appendicitis, but we did actually find a relationship between smoke exposure and long bone fractures, which we don't have an explanation, but a few hypotheses might be trauma in the setting of evacuations, or falls in the setting of a cardiovascular or respiratory event when they have smoke exposure. So there are a number of implications from this study. Our findings contribute to the evidence that wildfire smoke is associated with cardiovascular and stroke outcomes, particularly among older adults. And these implications are certainly present for frontline practitioners who can identify patients who are at risk of having these health outcomes related to smoke exposure and recommend behavioral interventions to decrease them. And we'll come back to that in a minute. There can also be, these results can also be helpful for surge planning for hospitals in the setting of these wildfire smoke events, particularly in regions where there are, hospitals that are stroke centers and cardiac catheterization labs that may experience higher than normal volumes. I want to talk about a couple of resources here in terms of helping address the issues of data access. I mentioned before that it takes months to collect all of this data and to do these analyses. And so we end up doing them retrospectively and they don't help us in the moment. So there are a couple of tools in development to help address that issue and collect real-time data to help us make decisions in the moment about potential health implications from wildfire events. So one of these is called SmokeSense, which is developed by some colleagues at the US EPA. And this is an app for Android and iOS. And it's a citizen science project, essentially, where people submit their own symptoms related to what they think might be smoke exposure. And everybody can partake in submitting their own observations of smoke and then also their own symptoms. And one helpful thing that it includes the data that we used in our study, looking at the density of smoke, and it also includes levels of air quality in that moment. There's also opportunities in there to learn a bit more about the health implications of wildfire smoke. So this tool was rolled out in 2017, and they performed a pilot study to look at the interest in using the tool and also some of the potential associations between health impacts. And they have over 25,000 users of this app. And this is just a couple screenshots from this app. I'm not personally involved in the study, but I've found it personally to be quite helpful to use to look at the air quality in my region and also the smoke plumes. So you can see here, it includes the detections of fires from satellites. The colored dots indicate the air quality from air monitors, and then the smoke plumes are generated from the satellite data. And as I mentioned, this is what we used in our study to determine the level of smoke intensity in each region. So this is a photo that I took these are a couple screenshots I took from 2019 from the Kincaid fire that I mentioned before in California. And this is available on the on the Android App Store and on the Apple App Store as well. So they've gone back and they've published some of their findings from this pilot study. So the map on the left shows the regions with the greatest number of smoky days that were reported in the app. And you can see the number of users as well, and sort of their distribution around the US. And they're focused primarily on the West because those are the regions that typically are exposed the most to the wildfire smoke. And this was from the 2017 wildfire season. Interestingly, they were able to capture some of the health implications from people who were using the app reporting their own symptoms. So not just gathering information about the smoke plumes themselves, but you can submit your own subjective health data and report your own symptoms. So some of the symptoms that people reported included cardiovascular symptoms like palpitations or eye irritation or respiratory complaints. So there was a significant relationship that they found in patients who have underlying COPD complaining of respiratory symptoms when they were exposed to wildfire smoke, which certainly makes sense in this context. So I think that there's an opportunity here to help at least educate the public and allow people to have a little bit more access to the information that we have in real time about air quality and smoke plumes, and also to contribute their own symptoms to help us gather more data in the moment about the potential relationship between smoke exposure and outcomes and health. One other opportunity I think to highlight is social media. This is from a research group from the Forest Service, and they've been studying the relationship between wildfire tweets and ground level particulate matter. So this study was from the fall of 2014 when there was a large fire in California, and they trended the number of tweets that were geolocated near the wildfire and the smoke plumes, as well as the particulate matter. You can see on this graph here, the tweets are plotted in red and the air quality is plotted in green. And you can see that they trend very closely. They found a very tight relationship between tweets representing the air quality levels on the ground, which is a challenge. A lot of these regions only have, one or two air monitors for an entire county. And a lot more of these, the location of the poor air quality can be much more nuanced. So this was acting sort of as a rough estimate. They used this tool again to do a separate study the following year, and they found, and they looked in a larger region, not just around one fire, and they found that the tweets again were related to the particulate matter on the ground, and you can see the association between the frequency of people tweeting about it and the particulate matter exposure. And then on the right, you can see the most common phrases that people were tweeting about, smoke being among the most common during that period of time. So now that we've talked about the health implications and how we can get a little bit more data in real time, what else can we do to limit the exposure and the health impacts from wildfire smoke exposure? So these are a number of recommendations that come from a number of sources. A summary from local and state health departments from California, from Washington, from British Columbia, as well as the US EPA. And they've been honing these recommendations over the past many years based on experience that they've had in trying to prevent health impacts. But it's really important to note many of these don't actually have any rigorous research behind them. That it's sort of what we've reached for to be able to communicate to the public, but we still have a long way to go to demonstrate a significant reduction in health impacts. So these recommendations include remaining indoors, reducing physical activity, using indoor air cleaners or air filters, wearing N95 respirator masks, and then going to clean air shelters or evacuating the region. And so I'll go into all of these in particular, but I think overall, these are important recommendations to consider that as frontline clinicians, you and we can give to our patients, each and every one of them, who, and your patients in particular, would be those who are at the highest risk category of future health effects because they have underlying lung disease, underlying cardiac disease. So they're really at the highest risk of having these health events. So I really want to emphasize that these are potentially life-saving interventions that we can talk to all of our patients about. So let's talk about these one by one. So remaining indoors. So we do know that remaining indoors can help reduce our exposure to outdoor air pollution by to roughly a third. This is one study that was looking at air pollutants outdoors and indoors, and they were monitoring them. And they found, you can follow the trend in the blue, and that when these peaks in outdoor air pollution occurred, just move my mouse over here. You can see where these peaks occurred in outdoor air pollution, that the indoor air quality trended along with it, but it was roughly a third of the exposure that they had outdoors. So just moving indoors can be a really effective intervention. Reducing physical activity is also really important to consider. Just reducing the activity reduces your respiratory rate, and thereby it decreases your exposure to those pollutants. So when you think about how exercise increases your respiratory rate 10 to 20 times, that can be a significant reduction in the overall volume of particulate matter and the other chemicals that we inhale. Using indoor air filters, like HEPA filters or standalone air filters. I actually have one in my office here right behind me. These can be really effective for reducing the concentration of particulate matter indoors. It's important to note there are some that are electrostatic and ion filters, and those can actually increase ozone within the rooms, and so that is actually not recommended. But the ones that just are mechanical filters for particulate matter can make a huge impact. And we know from research in the field of asthma that indoor air filters can improve peak flow and other respiratory metrics in children. And they've also demonstrated that air filters can improve cognitive functioning and test scores in kids who were in regions with high particulate matter exposure, but had indoor air filters in their schools. I will note that there's some limited data from the wildfire literature. There was one study that was done where they deployed air filters during a wildfire event in Southern California. And they found that these air filters helped reduce indoor particulate concentrations almost up to 50% and resulted in a reduction of up to 60% of hospital admissions and 40% of deaths attributed to wildfire smoke exposure. So really huge potential implications, but we need a lot more study on this. I think this also has probably changed in the last 2 years since COVID, but wearing N95 masks can also be a personal intervention to help reduce particulate matter exposure. I think there's one challenge. There's a lot of resistance from public health departments to recommend this because the fear is that if people are not fitted appropriately for an N95, they'll wear a mask that doesn't have a good filter, and then they'll go and do more activities outdoors. And so they will have a false sense of security that they're protected against the particulate matter. However, I think in regions that are affected by wildfire smoke for months on end, and then in light of COVID, where people have been more used to wearing masks, this may actually be an intervention that's really worth considering. So I think it tends to vary on the local health departments whether they will recommend this or not. But it's something that I think we might see more commonly in regions that are affected more by wildfire smoke. It's important to note that this is really not a potential intervention for kids because there aren't N95s for children. And it's very important to make sure that we're all fit tested and that people know that they have the appropriate size mask that fits well and has a good seal on their face. And then finally, these are more, the final two are more on population levels, but clean air shelters are something that some local health departments and communities have been deploying, regions where they have both simultaneously air conditioning and then indoor air filtration to provide a clean air shelter for people to go to when the air quality is just so poor. And so they can be indoor locations like gyms or auditoriums or other public buildings that would be a safe location for people to go to in this event. You can also develop a clean air space in your own home by choosing one room to put an air conditioner and or an air filter in and seal the room so that you at least have a room like your bedroom to go to where you spend 8 or 9 hours a day with improved indoor air quality. Again, there's really no rigorous evidence about this at this point, but it theoretically makes sense that this would be an opportunity to help reduce health impacts. And I think finally, evacuation is really the final method of reducing exposure. It most commonly occurs from the direct threat of the fire itself, but evacuation centers can also be deployed in regions when the wildfire smoke intensity is just so high and persistent. It poses some challenges because we're still having difficulty in predicting where the smoke plumes are going to travel. and we don't necessarily know the duration or the intensity of the smoke itself. So this can pose some challenges in identifying where those locations should be, where those locations for evacuation should be. There's also always the risk of evacuation itself, evacuation-related trauma, such as motor vehicle collisions, et cetera, can also be a risk of this. So overall, I just want to bring up the objectives again. Today, we talked about the broad public health implications as well as the economic implications of wildfire smoke exposure, and the impacts on respiratory disease and cardiovascular disease and stroke. And we know that at least from the data at this point, that the implications for health are really among the very old and the very young for the most part. So we've talked about how the changing climate is going to increase the intensity and frequency of these intense fires. And we talked about the wildfire smoke related health outcomes and vulnerable populations. We talked about the pathophysiology of changes to the circulatory system and the respiratory system. We talked about some opportunities in social media and using smartphones to predict smoke plumes and health effects for individuals, as well as opportunities to reduce our own risk and risk for our patients. And finally, to talk about the opportunities for and applications of this in the field of cardiac and pulmonary rehab, of course. I think there's still a lot of opportunities. We have a long way to go in terms of studying and validating a lot of these effects on cardiovascular disease and understanding why the outcomes vary so much by the studies that have been done. We have a long way to go to understand the long-term implications of exposure to wildfire smoke. Most of these studies are done in the context of one particular exposure, one season, or one fire, but we don't have a good sense of what the implications are for being exposed to wildfire smoke on a regular basis over the course of multiple wildfire seasons. There's a lot of other health effects that we have not yet studied, like metabolic derangements and diabetes, cognitive impacts, maternal health and child development. And we have a long way to go to understanding the vulnerable populations for these health impacts. And finally, we have room to improve on identifying the effective interventions for lowering our exposure to wildfire smoke, particulate matter, and decreasing the health impacts. And as I mentioned before, there's an opportunity for communication of these health risks to our patients for their own prevention efforts. I mentioned before, you are all very well suited to addressing prevention with your patients because it's such a high risk population of individuals. And this is an opportunity in a vulnerable period that they're in, maybe after an acute MI and in the process of cardiac rehab. They're at an ideal location to talk about things like prevention moving forward. And I think there's opportunities for each person to get more engaged in their own personal smoke exposure. And I mentioned one opportunity with the Smoke Sense app to do just that. And I just want to acknowledge this is the work that I talked about today is the result of an amazing team that I worked with for a long period of time. And I just wanted to express my gratitude to each and every one of them. Sumi Hoshiko at the California Department of Public Health, Anna Ruppold and Wayne Cassio at the US EPA, and then Jahan Fahimi and Bob Harrison at the University of California in San Francisco. And I want to thank all of you for your time and your attention today. And I would love to hear from you about your own experiences living through the smoke right now and caring for patients during this really critical period.
Thank you, Dr. Wetstein. That was very insightful. Really appreciate you doing this today. Got a lot of really good information out of this. I know me personally, I was really looking for a good tool to turn patients to, besides these air quality things where they just don't understand what it really means. And that Smoke Sense tool is going to be very helpful for me to get to patients directly right away that I can implement right away in my practice, even starting today. A few questions, a lot of these questions that I had were answered throughout this thing, but I found myself having a conversation with a patient the other day who was asking me, who has to be outside right now. He was wanting me to know if wearing his plain surgical mask was going to help him, and I was leaning towards the no side since there wasn't a sill. I mean, would you agree with that thought, or?
Yeah, unfortunately, there's been some data. Actually, the folks at the EPA in their human exposure lab have tried to look at this. Unfortunately, those surgical masks just don't seal on the face, so they may capture some of the very large particles. But what we know is that the health impacts are probably driven by the finer particles that can certainly go through a poor seal, but then they also don't get trapped by the lungs. Those are the ones that go into the bloodstream. So really the only way to capture those would be something like an N95. And those are just hard to work. They're hard to wear. I would, last year was pretty bad here, and I would wear one, taking my dog on a walk, and that was hard enough just walking around the neighborhood. I can't imagine what it would be like actually working outside in the heat wearing an N95. So other things you could do would be to try to time it with the time of the day. Sometimes the particulate levels change. Um, if you recall the image I had from the satellite, just the loop from yesterday, you can see how the particulate levels vary based on the time of day. And so that might be another intervention if they have to be outside.
Yeah, thank you for that. And another question that kind of is kind of brought up here is, a lot of this is mentioned that we really don't have the research on a lot of this area and things like that. And are you aware of any recent studies that are currently going on, or is there any that will be kicking off to start trying to get more information on this, especially related to health impacts, or is there anything that you're aware of?
Yeah, very good question. We're working on a study right now with the EPA. One of our interests was from a respiratory disease standpoint. People have raised the concern of what does wildfire smoke do to our risk of like COVID, for example, and respiratory illnesses the season later. And there's been one study on this so far, and they were looking at a particularly bad wildfire smoke exposure during the summer and the resulting effects on respiratory disease in the winter. And we do see changes that happen in the lungs when people are exposed to wildfire smoke that could put us at increased risk of having respiratory disease even 6 months later. So we're in the process of doing an analysis for that right now, but I think right now, unfortunately, a lot of the resources are tied to COVID, and I think trying to connect those two is one opportunity to help study that at the same time. We're doing so many things to try to, so many resources have been deployed to the study of COVID and prevention of COVID that I think there's a lot of potential overlap in terms of reducing our exposure. The droplets that transmit COVID are larger than the particulate matter droplets, so the surgical masks work. But I think still talking about masking and the whole way that we've changed our conversation around wearing masks in public has probably benefited us in terms of COVID, not to mention the use of air filters indoors for COVID purposes has also probably resulted in some co-benefit from an air pollution standpoint.
Yeah, just to give a little feedback on that too, directly what we're seeing here in cardiac pulmonary rehab is
Yeah.
we're getting post-COVID patients, those long haulers and things like that. And those ones are really reporting the smoke bothering them just as much as our COPD patients and our other lung patients would typically be reporting. So that's very interesting too. So, well, thank you again for the talk. We appreciate you being here, Dr. Wetstein. Thanks again to the board for setting everything up, and thank you, Trina, for helping us get this going today. We appreciate you setting up the webinar link and all that for us. Just so you guys know, save the date, our spring conference. We're actually going to meet back in person again come spring in Bozeman, Montana. It's going to be at the Hilton Garden on April 28th through the 29th. So look for those save the dates coming out in the next few months here. And also remember that we're going to be holding our election for our rolling over new board members. Again, we're looking for incoming president as well as secretary roles. Those are the ones that'll be coming through, but look for Survey Monkeys for the elections for fall. And if you are interested in yourself, we would love to hear from you. Just feel free to head over to the MACVPR website and reach out to any of the officers on that. We'd be happy to bring you on board and make sure you're part of that running. And then also, just so you guys know, you can catch us at the Montana Emergency Cardiovascular Care Symposium. That's going to be September 30th and October 1st at the Copper King Hotel and Convention Center in Butte, Montana. MACVPR, we were able to actually secure a speaker, so we're sponsoring that event. I put the link for that if you guys are curious joining that, but we're going to have an individual there talking about secondary prevention for coronary artery disease with a primary focus on cardiac rehab. That's something that's typically missed at that emergency conference, and they're more focused on STEMI care and things like that. So it was a great way for us to get our foot in there. We'll also have a booth set up there. So if you're there, make sure you stop and say hey to us. Thank you again, Dr. Wetstein. Appreciate you being here. If you guys have any questions further for him or the board, please just reach out and I can try to make that happen to get you in the right contacts as well. So thank you again.
Thank you all. Stay safe out there.